morning, and it's great to be here at yet another A-CURE meeting. This is the fourth annual A-CURE meeting, and I'm just going to give just a few words about where we are, what we've achieved, and where we're heading a little bit. So first, I want to remind everyone about the mission of A-CURE. The mission that we've established is to advance the science and mechanistic understanding of acute cardiac unloading and support, and the translation of basic and clinical research into therapies aimed at heart muscle recovery. And I think that, as you've seen it over the years, there has been we've really made strides to achieve this mission. So this just shows a little bit of the history where we started. The first session was in 2015 in Paris. So 2015 we had our faculty meeting, first faculty meeting where we organized the symposia. 2016 the first session was in Rome. Our first keynote speaker was Dr. Braunwald. 2017, Barcelona. You see here also the number of abstracts is increasing. Dr. Fuster delivered the keynote address. We also announced the start of the Door to Unload STEMI trial, the pilot trial. And 2018, last year, our third meeting was in Chicago. Again, an increase in the number of abstracts and participants. Dr. Udelson provided the keynote address, and it was right on the dawn of announcing the results of the Door to Unload study. And now here we are in 2019, that we are now here in Paris. And again, number of abstracts is increasing. Hopefully, from review of the abstracts, the science is also really markedly accelerating, and we're extremely fortunate to have Dr. Doug Mann here today to deliver the keynote address. And also some of the highlights for this upcoming year. The Door to Unload pivotal trial is commencing, and also we're going to hear a lot about the PROTECT kidney trial, which is also going to be commencing. So that's kind of our history of this meeting. So we're all about unloading. So what is unloading? We offered up this kind of definition of what unloading is. We define unloading as the reduction of total mechanical power expenditure of the ventricle, which correlates with reductions in myocardial oxygen consumption and the hemodynamic forces that lead to ventricular remodeling. If we look at this in terms of pressure volume loops, what you see if we start with a normal loop, if we start here with a normal pressure volume loop, and now there's an insult to the myocardium, there's a reduction in contractility. And you see here that with a reduction in contractility, there's a reduction in stroke volume blood pressure and also elevations of wedge pressure. And left unchecked, and if this persists, we initiate a process that's referred to as ventricular remodeling. And this really is a result of sustained neurohormonal activation and also the physical hemodynamic load. And then this is manifest as rightward shifts of both the end systolic and particularly the end diastolic pressure volume relationship. And then you wind up with chronic heart failure. So our mission here is to prevent this from happening, or once it has already initiated, to reverse it. And this is now, if we start out in a heart failure state, we aim to introduce therapy. And in our case, we're particularly interested in mechanical unloading. You see that the goal is to bring these relationships back to normal. So this is now, number one is to prevent this from occurring. That's the ultimate goal here. And once the other part here, though, is once it occurs, if it occurs, that we can reverse it. And again, our main interest in this symposium is related to the effects of mechanical unloading. So what do we get with unloading? Linking back to our definitions, first of all, decreased wedge pressure, which of course reduces the wall stress on the myocardium, but also relieves pulmonary congestion. This also results in a reduction in myocardial oxygen consumption. This unloading can also improve coronary blood flow. These all work together to achieve myocardial salvage. And finally, this either limits or reverses the remodeling process. So these are kind of the spectrum of things that we are trying to achieve. So I showed this last year. When I think about unloading, I always go back to this study from Mark Pfeffer, Janice Pfeffer, and Dr. Braunwald, where they showed that in rats with myocardial infarctions, looking at the ex vivo end diastolic pressure volume relations, that if you have a large untreated MI, you'll see that compared to the normal range, the end diastolic pressure volume relationship is markedly shifted out towards the right. But if you treat these animals at the time of MI, in this case with captopril, the degree of rightward shift is blunted. And this is really what we're trying to achieve, but also we're trying to achieve this in a much more profound way than you see here. And the bottom line is that What are the mechanisms that underlie the modulation of that shift? We think it is largely related to the changes in the mechanical forces. This was a clinical study that followed shortly after those basic science studies in rats, showing in patients that the use of captopril markedly reduces the end diastolic pressure and the wedge pressure in comparison to control. And also there you see on the far right, blunts the increase in diastolic volume. So this was an example of a very rapid translation of basic findings into clinical practice, which of course then these studies led to the SAFE studies, which underlie now our use of ACE inhibitors in the setting of acute MI. But there are inherent problems with and limitations of using pharmacologic approaches to achieve this unloading. And the issue is that the more you unload the LV pharmacologically, the more you also compromise aortic pressure and cardiac output. And this is also particularly the case in the setting of cardiogenic shock, where we can't use any of the drugs that we know to be helpful to prevent remodeling. So in come now mechanical support devices. Mechanical support devices are really the ideal platform for inducing reverse remodeling in the setting of ischemia and also in the setting of cardiogenic shock, because you simultaneously unload the ventricle, as you see on the pressure volume loops at the top, but also at the same time what you see at the bottom is that you support the system, the body, and the blood pressure will increase while the ventricle is simultaneously being unloaded, and this is obviously something that you cannot achieve with drugs. So in the setting of MI, we've known for many decades actually that unloading the ventricle during ischemia and reperfusion, that you can markedly reduce infarct size. This is from Bart Main's study that was done with one of the early versions of Impella in sheep studies of infarct, and you see compared to the control, if you unload during ischemia and reperfusion, a marked reduction in infarct size. If you only unload during reperfusion, you have a benefit but less, and if you only partially unload, you still have a benefit but even less. This was then recapitulated in Naveen Kapoor's lab. You see here the comparison of infarct size with primary reperfusion versus primary unloading. Unloading the heart before reperfusion, you have here about a 50% reduction in the size of the infarct. And this, of course, led to the pilot trial, which showed, in my mind, this is really the key finding from this study. In red shows the infarct size as a function of the area at risk. In blue, you see patients who were treated with 30 minutes of unloading. Infarct size appears to be, in this study, relatively independent of the area at risk. And this is really the basis now for moving forward with the pivotal study. So we've talked mainly about what happens when you unload the heart in the setting of an acute MI, a lot of the studies, but from human experience, we also know that unloading a ventricle that is chronically loaded can also induce reverse remodeling. So here you see ex vivo end diastolic pressure volume relationships from hearts of patients who got transplanted, either de novo heart failure without a left ventricular assist device, that's in pink. In blue are some normal hearts, and red are patients who had severe heart failure but were supported with a left ventricular assist device for about 6 months. And you see here that, of course, the patients who received left ventricular assist support, the end diastolic pressure volume relationship is shifted markedly back towards normal. And this is the process of reverse remodeling. And what we also have described is that this process is both dose and time dependent. So these are all patients who were treated with a HeartMate device, and you see the diamonds are the patients who had no support. Then the squares show patients who were supported but for a very short duration. Then the triangles are patients who were supported for more than 40 days. And you see here that as time goes by, there's a progressive leftward shift of this curve back towards the normal. Does not quite reach the normal, but gets back towards the normal. And in addition, with regard to dose, these are results from a study that was also done in Bart Main's lab. Again, patient hearts that were supported with a Circulite device, which provides partial support. And you see these are patients who are supported for more than 40 days, but whose hearts did not fully reverse remodel. So again, this is speaking to the dose dependence. So unloading, just like a drug, has a dose. The more you unload, the greater the effect will be. So that really sets the stage for a lot of what we're going to hear today. I will introduce Dr. Mann later, But Doug has been a pioneer in the fields of remodeling and LV unloading-induced reverse remodeling, myocardial recovery, and remission, as I'm sure that we'll hear a lot about the molecular underpinnings of these processes. So with that setting the stage, we have a very packed agenda, and we'll be hearing both advances in the science of acute unloading and myocardial salvage, both basic aspects and clinical research, and we'll then look forward to Dr. Mann's speech later on this morning. Thank you.